Good evening from Hong Kong. Welcome to the fourth and final episode of Asia's Post-Pandemic Healthcare series organized by the Institute for Health Policy and Systems Research. I'm Jeffrey Liu, founder and chairman emeritus of the Institute and host of this series. Co-hosting this evening's program is Ms. Elaine Chen.
Hi, everybody.
Elaine is a board member of the Institute and a health insurance expert in Hong Kong. She is also an entrepreneur and strategic advisor in developing new platform solutions of healthcare payment and delivery in the private sector. Joining us this evening are Dr. Suit and Dr. Ataya from Thailand. Both Dr. Suit and Dr. Ataya are experienced healthcare professionals, and they have made stellar contributions as expert advisors, policy influencers, researchers and educators in public health and in health systems development, financing, and management. And Dr. Suit and Dr. Art, welcome to this final episode of our series. Now, in the previous series, our expert friends from Singapore, Thailand, and Japan have shared with us their views of the tremendous strides Asia has made in enhancing and protecting people's health. But they also recognize that there are still many challenges confronting Asia's health systems in the future. Some of these include areas such as improving equity and access, costs and efficiency, quality and outcomes of care, governance and management, as well as institutional arrangements. And of course, the COVID-19 pandemic has exposed both the strength and weaknesses of Asia's health systems much more visibly than ever. To begin our chat this evening, I have two questions for you both, Dr. Suit and Dr. Art. The first question is, what do you both see are the unique aspects of Asia's health systems, and how do you characterize their accomplishments in past decades? This is the first question. The second one is, what areas where clearly advances or improvements should still need to be made or worth making in the coming years? So I lumped the two questions together, and so maybe we'll start with you first, Dr. Suit.
No, lady first.
All right, okay.
Thank you for the question and the opportunity for us to share. I think that for Asia's uniqueness, our difference make us special because we are very greatly across and within our region, regarded to ethnic group, culture, environment, economics, historical ties, and political system, ranging from democracy, socialism, absolute monarchy. And also has a mix of many different climates, from hot desert to the polar in Siberia. And we are the biggest and populous continent, which is viewed as the very big market. We can produce, or we are provide the opportunity for economy of scale. For the health system, it is quite pluralistic, like ranging from public sector domination in like Indonesia, Thailand, and Hong Kong, or private sector domination like in Japan and Philippines. Mm-hmm. But we still have some uniqueness of Asian value. I think that there are two points of uniqueness. First one is the long and continuity of traditional knowledge in Asia, in particular traditional medicine. In several countries, Asia have traditional knowledge that has been developed and passed from generation to generation for thousands of years. And the traditional medicine as well is the essential element in health, like some of the acupuncture, we know that. And for the herbs, like Xinghao, that is the original substrate of artemisinin, traditional massage, or the world renowned. I think this is our uniqueness and our asset. The second is the spirit of health personnel and some kind of Asian value like doctor-patient relationship that I observe, and including the Asian hospitality. In the health system, I think that in some country in Asia that has successfully well-developed health system, like in Sri Lanka for the very unique health maternal and child health success, or some we can see in social media on the spirit of health personnel during COVID that they devote for the patient and the people. I think that the spirit of health personnel to the benefit of mankind is a very unique characteristic in Asian. And the Asian hospitality as well, that we learn from the from Taiwan, from Singapore, and in Japan, that we have the world leading health service institute and bring us to the top medical hub in the world. This is together with Asian hospitality, which is our uniqueness.
Well, let's pass this on to Dr. Sweet, because I think Dr. At just mentioned two very prominent or significant things regarding the Asia health systems. But more broadly, I think what has been described is that we have a long history of tradition, and our values could be quite inclusive. As I read what you're saying, we're very modern in terms of Western medicine, but we're also very traditional in terms of our native practices of medicine. It's still, very prevalent. So that's a unique aspect of it. The second thing is in terms of the culture and values that we have developed, nurtured in the medical field or in the healthcare field. There's a tremendous respect towards doctors or healthcare providers, more so than perhaps in some other countries in the other parts of the world. Do you agree with that, Dr. Sweet, or do you have any further comments on those 2 points?
We are part of the so-called dragon net. I think one of the uniqueness of Asia is the root of the dragon. If you look at how Asian countries do in terms of COVID or even universal health coverage, you see those countries that have deep dragon root, from Republic of Korea, People Republic of China, Taiwan, Hong Kong, Singapore, Thailand, even Vietnam, are doing quite well in controlling COVID. I think this is one uniqueness that you mentioned, that we have, particularly the Chinese history, the dragon root, which dated back at least 5 millennium, 5,000 years. Non-stop culture, religious, language, everything, including technologies. So these are the root of Asia, not mentioning those in Persia, in India, a very, very old history and wisdom, which still deep-rooted in the mind, the spirit of the Asian people.
Well, I want to follow with one quick question before I pass the floor to Elaine. Now, we have a long history of traditions in one way or the other, okay? So the root of the dragon, but it is also spreading out. Do you see this traditional values eroding in the future in light of all of the technological advances that we're talking about and have been introduced into the practice of medicine? Or do you see that would actually become a facilitating factor of evolving some kind of healthcare systems that may encompass some of this uniqueness of the Asia values in the future?
My concern is we must not let it being eroded. We must maintain it. We must conserve it. We must further develop it, expand it. For example, when you look at universal health coverage, which is the policy and the commitment of all the Dragon Net countries. Even Vietnam, although they are struggling, they are quite close now, 90% now, very close. But when we talk about universal health coverage, most people think about money. But actually, universal health coverage is the access to universal access to essential health services without financial barrier. It's the access. And the access depends on the spirit, the commitment of the health professional and the equitable healthcare system. Even though you have free healthcare services, but if the healthcare services is low in quality, bad in responsiveness, it won't be universal health coverage. So if you see the evolving situation, particularly in the last 3-4 decades, you see more and more commercialization of healthcare services. Dr. Art just talked about medical hub. You know, country like Thailand has more than 3 million before COVID, 3 million foreign patients a year. This is highly commercialized. Now when there's no foreign patient, they come to the Thai people, which is okay, because when they come to the Thai people, they join the universal health coverage. They have to accept our price, our payment system. Okay, so we have to live with the fact that trading improves economies. The challenge is how to make sure that this economic improvement, economic gain, will be distributed more equitably. I'm not saying equally, but equitably among all part of the population in each country.
And this is the first time I heard about two of the professionals talking about culture, traditional knowledge about Asia and how the uniqueness of this kind. And I love to hear about the hospitality among the 8 regions, that how we treat the patient, how we take care of those. And it is really inspiring me that when you talk about this topic, I think about the overseas. I think about Europe. I think about USA. Well, this is really a difference. And I really realized about the challenge, like commercializations this day. Can we make our original culture, root, hospitality be consistent like before? But my challenge to you, Dr. Sui, you're talking about like commercialization is one of the inhibitor factor. But this is the world. The world is moving very fast. So definitely, we cannot just thinking about commercialization. We cannot do better. But how to balance the whole things? What do you think? How you think about how to balance our roots of Asia, our traditional knowledge, and our hospitality compare with commercialization? How we can, as a medical profession or as a hospital policy builder, can make the whole things work and equally?
I will let Dr. Ataya reflect her idea first.
Sure, thank you.
How the younger generation doctor think about this issue.
Very good.
First, I think that we should make this to the global agenda, both maybe like for the health professional movement and training, that the curriculum should be tailor-made to the national context and include the social and spiritual aspect, the moral development. This is very crucial. Also, in the education system, that think first for the public. I think this is a first point. The second point is, I think that if we have the good governance in the system, from the central, like some board member governance system, to the local, if we can ensure the accountability, partnership, and social ownership in the system, not only health system, I mean that all the system at the country level. I think that this should be keep the pace and balance between commercialize and the spirit for the whole and for the public.
While we are having this session, there's another parallel meeting, virtual meeting, the IHPSR, Asian Action Alliance on Health Professional. Actually, it's Asia Pacific Action Alliance on Human Resource for Health, IHPSR. They convene the annual biennial conference since 2005. Today is the opening session. And one of the main activities at the opening session is to deliver the award to outstanding committed health professional from around 17, 18 countries in the region. So you need to recognize those who committed, who has committed spirit. These are health professionals who commit themselves to work for the people, particularly in the remote, difficult areas. And this has been the tradition of IHPSR for the last 15 years. And we'll move on. Okay? So social recognition is very important. You talk about how can we cannot stop commercialization. We have to take balance. I am chairing the Universal Health Coverage Board for Bangkok now for 4 years. This is the first year. I want to give that as an example that Dr. Athiya talked about good governance. This board previously is full of providers talking about how they divide the money. So when I came in as a chair, I appoint more civil society organization, the people to take balance, including the elderly group, including the disabled group, including the people living with the disease. 9 representatives of civil society organization on the board. This is public, this is government. You have to get them involved in the governance of the public policy. Of course, I also include private clinics and private hospitals, not only public. So they have to work together and we learn. Still the same. Mostly talk about money, 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 money. As an old man, before every meeting, I always remind them that we are here to talk about the people.
Let me inject here, Dr. Sweet. I think you're talking about a trend of democratization of medicine or the practice of medicine, because introducing or including more laymen and non-healthcare professionals representing different segments of the civil society is certainly what a lot of people suggest that must be done. Do you see this trend necessary and should be continued in the future?
Oh, Jeffrey, there is no need to ask this question. You look at the global level, the global fund to fight AIDS, TB, malaria. It managed more than $3 billion a year for 3 diseases, much more than the budget of the World Health Organization. It has 22 board members. 5 of them are from non-state actors. 1 from the private sector, 1 from the private foundation, and 3 from NGO, including community of people living with the disease. You see that also in other global health partnerships. It's the world trend. The previous governance, or even the mainstream governance system now, is mainly state governance by state, and governance by market, let the demand and supply govern you. But the world is moving in the direction of governance by partnership. And governance by partnership is the most important component of good governance. We believe that it is very difficult to be selfish in front of the public. When every partner sits around the table, if you want to express your selfishness, you have to be careful and think twice, right?
You know, one of the issues I think we need to be mindful of is not that it's not a trend that we should support. But if you look at COVID-19 and how different countries are dealing with it, it seems like everybody's pointing to the government as the one accountable and responsible for the well-being of people under COVID-19. So the civil society participation in that is not as much as I think for various reasons, you know, in dealing with this major pandemic that we have.
When a country faces a war, you need the government to take the lead in fighting the war. Do you think COVID-19 is a war? If it is, then you need the government to lead, and not only health sector, but every sector. But at the same time, if you are going to be successful, you need people to support you. Even in the real world war, it's people who has to support the government, but it needs the government to lead. So I think even in every country, if the people don't support the government asks them social distancing, they say no. The government asks them to wash their hands, they say no. The government asks them to wear masks, they say no. No way that a government can control the COVID-19. It's impossible.
Yeah. Well, I think and you're making a very important salient point. I'll pass it back to Elaine in just a second. I think what you're saying is, yes, the government must be in the leadership position, okay? Because healthcare is you know, an ongoing war in a way, because we're fighting a lot of things, although COVID-19 is a very visible thing because we see immediate impact. But you know, poor health and all of these other issues that we see in public health actually is a war in some way, okay? I agree with you. The government should need to take the lead. But I think it also needs to be inclusive in terms of that leadership. You know, you put it in the context of civil society support, which I think is very important. Do you see Asian governments being more inclusive in terms of how we want to deal with healthcare? Because in the past we talk about essentially healthcare professionals, particularly medical profession, in taking the lead in you know, driving or developing the healthcare systems that we have. Do you see that becoming more inclusive, to have different segments of the civil society brought in to the government?
Jeffrey, no one who is in power want to share their power. So no one who is at the top, few people who are at the top want to include lower level, less power, less authority, less power people to share their power. Very few of them.
Yeah.
So you have to fight. You have to fight for it. You cannot wait for the government leader to ask you to get involved. You know the history of the Global Fund.
Sure.
It was the NGO, the people who live with the disease, who fought for the fund. And that's how they sit on the board. I was the board member twice. I used to be the vice chair. I can see that government representatives do less homework than NGO. They are much more active. They do more homework. They do more lobbying. You need this kind of strong citizen. So you see in Thailand now we are having demonstration. Right? At the moment while we are talking, tens of thousands of people on the street in the central business district campaigning for constitutional reform.
Well, thank
Yeah.
you very much. I think you made the points very clear. I think the messages are there for us to take.
Very good discussions about the culture, everything. And I want to add on a word of this one, because in commercial world, we normally these days always talking about customer experience. And this is how we make the business happen. And now what you guys talking about, all the professionals talking about tradition and everything, it made me think about patient journey. All these old days, people may not be just thinking about patient journey, but thinking about policy, everything. But with all the tradition, all the culture, we should have focus on patient journey, how we start the whole process instead of building up the policy. I want to jump to COVID-19 again, because this day, during the last years of COVID-19 situations, there was a lot of change, like promoting telemedicine, population health, and even some kind of big data, those kind of things, because everything was virtual, digitalized. After the COVID-19, how you think the health will be evolved to future?
I think that it would start from the demand side for the patients. They know very well that at this war, at COVID time, they don't want to go to the hospital. Mm-hmm. And this is in the case of Thailand. Some of the project, like we have the drugstore policy, that we will use the drugstore as the point to provide and distribute the medicine for some chronic patient. And during COVID, it is very good opportunity to expand and evolve this policy. I think that this is this kind of thing of the decentralization of healthcare will be like a one part. And telemedicine, there are even telemeeting. It is quite very difficult before COVID, but during COVID, it can evolve very rapidly. And the movement that now they are working on the legal barriers to overcome the telemedicine in Thailand or in many regions. So I think that the direction is go for not institutionalized services. It will be more telemedicine, and we reiterate the importance of primary health care to the community level, and the village health volunteer proved itself that more decentralization, more strengthening of the community health system is very important. This is
your question, Irene, may be whether these new things will be a new normal. Telemedicine be a new normal. My answer is that we must make it a new normal. Mm. You see, if you go to a public hospital, at least in my country, you see so crowded, so many people there, and waiting in long queue, waiting for drugs, waiting for to check the blood. If you go to the room that they draw the blood of the patient, they have to wait for half an hour, 1 hour, just to draw the blood. And why they have to staff overnight. Now we have a motorbike with a technician to draw the blood. It will be paid by the universal health coverage. Telemedicine paid by the universal health coverage. But will it be a new normal? It will be only when it becomes the demand of the people. Mm-hmm. We have to realize that healthcare services need human touch. It needs human touch. Telemedicine cannot replace human touch. But for patient, for example, a patient with chronic disease, diabetes, hypertension, instead of coming to meet the doctor face to face, every 2 months, they may come only twice a year. And then the other 4 episodes, they meet through medicine. This at least saved 2/3 of the visit. And we have more and more chronic disease patients. I also chair a committee to assess the filling of medicine, filling of prescription by pharmacy, private pharmacy. In almost all hospitals in Thailand, even clinics, the doctor, the hospital has a pharmacy in the hospital who fill the prescription. So the private drugstore only sell their own drug. Now we started, even before COVID, but boom during COVID, that they come to the hospital like the chronic patient. They come to the hospital only twice a year. And the other four sessions, they just go to the pharmacy, which has connection to the hospital. And the hospital are very happy. The patients are very happy because they don't have to go into long queue. The pharmacist can advise them on the drug, can measure their blood pressure, can assess their blood sugar. And if there's any problem, they connect to the doctor in the hospital. I asked one of the hospital director, why do you do this? Why do you join this program? He said, why not? I have 18 pharmacists working for me in the community free of charge. I don't have to pay them. The universal health coverage pay them. And my pharmacists in the hospital, I can use them to take care of the patient in the ward, the inpatient, drug interaction, advice on drug or whatever. So you have to make it become the demand of the providers as well as the patient. Once they are addicted to it, it will be a new norm.
Very good. Well, very good. I very love to hear that you endorsing the new normal is a must. I very appreciate this part because I want to share you a conversation. I just talked to one of my friends, which is the insurance department claims head. She's telling me that, Elaine, I just tried telemedicine for my year. I will never go to clinic now. I just use the telemedicine. This is perfectly good. And then the medication is just come to my door. I love the service. So this is exactly what the COVID-19 facilitate the whole things to make it faster. And also what I see is, given all this, like your previous experience of patient queuing in the hospital for blood tests, for taking the medications, everything. But now, because of COVID-19, what we just talking about the patient journey is starting to click in. We think about people, how they react, how they feel when they say, and how the whole journey. Another challenge here, we all talking about the good things. We all talking about how good we should go for telemedicine, how good we can release the resources, how good we can focus on different things. What is the inhibitor for us to move forward?
There is no hurdle on technology. The biggest hurdle is the mindset of the providers. Doctors still want to control. If the patient has to come to them, they are the boss. Okay? If they see so many patients queuing, waiting for me, they feel good, they feel powerful. I'm a doctor, I know. But when you start to do telemedicine and you see the power of these tools, you gradually change. Initially, I have to go before COVID. I have to leave my house every day in the morning, even though at this age, so many meetings. Nowadays, my secretary managed for me that I won't leave my house more than two days in a week. The rest, we go by virtual meeting.
Right.
Today, they want me to go out. I said, no, today is my rest day at home. So I'll go virtual meeting. And we can participate in virtual meeting very easily, like we are talking right now. We have no gap, right? And even in my own office, the IHPP, we have a target that on the average, and we monitor it daily, on the average, only 50% of our staff come to the office in each week, not more than 50%. And we monitor it. So every unit have to have the data, whether they come to the office or not. This is contrary to the bureaucratic system. You have to sign in, you have to sign out, right? Don't take me as an example because I'm a rebel. From the first day of my career until I retired, I never signed in and signed out. They want to take disciplinary action on me. I said, go ahead, do it. You know damn well I'm the one who come every day to open the door of the office. I'm the one who close the door and lock the door of the office. If you want to do disciplinary action on me, okay. And if you want to force me to sign the name in and out, these are fake things. I won't go with fake things.
Both of you are doctors. I can't help but ask you a question because implicit in what you're saying, Dr. Sweet, there are people that are not rebels. They are stubborn and they may not want to adopt new technology. And now, what if somebody is not a rebel, how would you change their mind?
My question as well. Thank you, Jeffrey.
Yeah. Both doctors. I mean, we have Dr. Ataya, who's younger.
I think the younger lady may have some better tactic than the old man.
Go ahead, Dr. Art.
I think that we can do both for the system. If we have policy and system, this is like a first step to do first, to adopt the telemedicine. This could help. But the other aspect is, I think that is from the social or the patient side. If there is some demand, like in Thailand, that we have Grab taxi, and the government always say that it's illegal to call taxi, to use the app. But for the customers, they want it because they don't want to, oh, taxi, I would like to go there, and they reject and they decline. So Grab can go very well because the demand for it. And I think that we could use both the policy to control and both for the social advocate to drive the telemedicine or more difficult policy that would change the mindset. And when the time pass and like a doctors or health personnel can see the advantages or the benefit, they will gradually change their mind. Like at this time for the COVID, that bring the new thing, bring the new normal in some activity and aspect.
Myself nowadays seldom drive, although I have a few cars in my house. I always call Grab taxi and pay maybe less than $10 for the almost 1 hour trip. But the time that I have in the car to work is worth more than $10, maybe $100 or more dollars, right? And I don't have to be stressful in driving. So these are new normal, which is not forced. When you want to change something, Jeffrey, you know Machiavelli, right?
Yes.
Yeah. It's most difficult. In The Prince, he said, it's very difficult to innovate new thing or change the old thing. Very dangerous as well. Why?
Obviously, yes.
Why? Because those who benefit will just stand aside, watch you fight. And if you succeed, they come in and get the benefit with you. But those who lose the benefit, they fight you to death. So if you want to change, you have to use both incentive and motivation. These two terms are different. Incentives are external force to push or to pull you to move from one position to the new position, or to change your mindset from old mindset to new mindset. Push or pull. Grab is incentive, definitely. But the second one is more important and more sustainable. Is motivation. Motivation is like internal engine. I want to do it. This is something I want to do. No one can stop you. I have my own energy. I have my own drive. I'm happy to do it. Many of our rural doctors work in the very remote rural district for 20, 30 years throughout their life. You ask them whether we pay them well, they stay there even before we start to pay them more. And they have many more opportunities, but they said, this is what I love to do. They have motivation. And one of the things that we can motivate them is to recognize them. In Thailand, we have a annual Outstanding Rural Medical Doctor Award. You know, given by whom? Given by the equivalent of Hong Kong Medical School, the oldest and most prestigious medical school in Thailand. The professor has to go around the country to see, to observe, to visit these rural doctors. And then each year they choose one. And they invite this doctor to give a special speech in the medical school, oldest medical school. And the audience are the medical students, lecturers. These are big motivation, and they are role model for other doctors. I'm not saying that all doctors in Thailand are like this, but at least we can maintain our universal health coverage by paying only 5% of our GDP. And our universal health coverage includes everything from paracetamol to cancer therapy, even chemotherapy. We even have home chemotherapy now paid by universal health coverage, free of charge, like the UK system, tax-based, okay? Because of the spirit of these people.
I have one last question. Well, after all this change and, well, you two expert on the, well, about the culture, roots of Asia, everything. So what is the two priority you think in the future we need to change and need to focus, and what kind of resources we need to support this two important priority?
I think that we should go for 5 things to like a GRASP, GRASP. G is mean good governance that we have discussed prior to this. R, we should invest more on the research and regulatory capacity, which is the brain and will lead us to the evidence-informed policy direction which, for the future. And A, we have to invest continuous investment for adequate and equitable health delivery system. And for S is for financing. We have the sustainable financing adequate for essential services and efficiency. And the last one, the P, is the political commitment and social ownership. I think that this 5 area is the key point, and we have to invest and proceed more to make it better.
What she mentioned, one thing which I would like to highlight is the capability of the government to regulate the private healthcare sector, to bring them into universal health coverage with committed spirit, good services mind. And most important thing is to bring their efficiency. We know private sector is much more efficient than the government, although they make profit from the efficiency. Of course, they make profit from some bad thing as well. But that's the job of the government to regulate. So the capacity of the government to regulate is very important. Elaine, you talk about the balance. This is the balance. And the government capacity to regulate is usually low in developing countries. Government officers are usually bribed or corrupt. That's why we need participatory governing structure. That's why we need people who are the main beneficiary of the healthcare system to also sitting on the driver's seat, not to let the government officers who can be easily bribed or corrupt to be only the one who sit on the driving seats. I have one thing to protest, Jeffrey.
Yes.
How come you are not a medical doctor, but you are the former DG of the health hospital administration? You are not a medical doctor, but you govern the doctor. That is unfair. It's not happened in Thailand.
Well, you know, health is not a monopoly of anyone.
But hospital.
Well, hospitals too, right?
Please convince the Thai doctor.
I'll be happy to come and convince the doctors in Thailand or anywhere. But I think, you know, you have pointed out a number of things, both you and Dr. Sweet and Dr. Art. I think I wish we have more time, but I want to close this session by asking one question. We had been talking in a rather optimistic and positive way about future healthcare systems in Asia, without specific reference to any particular country, although, you know, our perspectives would come from our own experiences. Obviously, we have our own perceptions, you know, from that angle. But if we move forward, just as a reference for, you know, all of our counterparts in Asia who want to develop a better healthcare system, a more sustainable healthcare system, we cannot carry everything forward. There must be something we ought to drop, shed, or discontinue. If there would be one or two things we want to drop, because for whatever reason, these are going to be burdens of some sort for us, what would those things be that we should stop doing, discontinue, or no longer carry forward? Should I go with the lady first and then the gentleman later?
I think what we should drop is, I think that for the commercialized healthcare system, I didn't mean that commercialized is not good, but I think that we should keep balance between commercialized and the public system. The second is the technology-driven professional training, because I think that we should have the capacity for appropriate technology, and the health professionals should use appropriate technology with high touch and appropriate tech for the people. This is, I think.
Okay.
What we should drop is to stop the vertical bureaucratic structure of the state-only governance system and move towards participatory governance system. What we should stop is to stop the traditional training of health professionals or health leaders, but move to more sustainable, publicly oriented health professionals and leaders. The future of healthcare system is in their hands. If you let them grow up with greed-based idea, greed-based concept, then your healthcare system has no future. We must educate them. We must build up their capacity in a sustainable way. Let them see the public situation. Let them work for the public. It doesn't mean that they have to be in the government. Many private sector people do for the public more than the government official, but they should have public in their mind. While making profit, we may need more social entrepreneur, more and more social entrepreneur in health. Over to you, Jeffrey and Irene.
Thank you very much. I couldn't have asked for more. I know you were promising maybe at most 45 minutes for us, but I think we've gone beyond that. But I think we will very much deserve that extra time. We'll come back in the future. I'll just mention that in just a little bit, but I want to officially thank both of you, Dr. Sweet and Dr. Art, for sharing with us your insights and vision of what our future healthcare systems should encompass and how we should seek to move forward to develop more sustainable, effective, and responsive healthcare in Asia. And I really feel fortunate to have both of you in our ending final series, but it won't be the conclusion of what we try to do. because we'll be organizing a summit with our expert friends like yourself from our series, and also from around the world to talk about Asia's future healthcare. And I think with that, I want to close and say good night to you all. Until then, stay healthy and safe. In addition, a little advertising for our channel. Please subscribe to our channel and stay tuned. Thank you very much. Good night.
Good
Thank
night, Jeffrey
you.
and Elaine. Good night.
Thank you. Thank you.
Bye.